It is my distinct pleasure this afternoon, South Africa time, to introduce Dr. Tandaza, who wears many hats, primarily as a family physician, but with significant research interests in psychiatry, as well as a deep commitment to improving access to education and medicine in rural South African communities. He's a family physician and academic at the University of KwaZulu-Natal, and a fellow in College of Family Physicians under the Colleges of Medicine, South Africa. Dr. Tandaza has a master's in family medicine and is pursuing a PhD as well. As a clinical training lead, he's very interested in improving access and exposure to medical training in these rural settings, and has actually authored a few books, sort of training in family medicine as well. Dr. Tandaza is a key international partner for us here at DGUSOM and has a wide-ranging expertise, but today will talk to us a bit about psychiatry and sort of mental health care in rural settings in South Africa. So I'll sort of moderate a Q&A when the major presentation sort of finishes, but for now, I'll just leave it to you. And thank you so much for joining us.
Thank you very much. Yeah, and thank you to the team and Tracy and the team just for always allowing me to be able to speak to you guys. I know we are far apart, but it has been nice to have actually been within your corridors for a little while and to actually see how you guys experience life and medicine and training in medicine. So that was really wonderful. And I certainly hope that some of you, if not all of you, will one day come through to South Africa or parts of Africa and actually practice a bit of medicine in these settings, just for experience and yeah, serving different communities. So yeah, so it's really an honor for me to be able to speak to you today about mental health in rural South Africa. And so I'm going to share my slides and I'm going to try and keep it interesting again, Tracy. Some of the information is going to be repeated information, but there's always nuances, I guess. They say, you know, you see something once, you see it again, and there's something different that you pick out of it. Yeah, but I really hope that it will be something that just allows everyone to get a picture of what we experience when we talking about mental health in a South African context. Okay, and then I'm just going to remove a couple of things from my side. Okay, great. So I think, you know, when I'm asked to talk about mental health in a rural South African context, I often find myself sort of thinking, whose mental health exactly am I focusing on? You know, is it the healthcare worker? Is it the patient? Is it the system? Is it the community itself in terms of a rural community? Yeah, and so there's just these different aspects that one has to think about. Is it culture? You know, is it the environment? And so that always just brings about questions. And so oftentimes I try and bring the different aspects of it. And I think as healthcare workers, obviously we are involved in all the different aspects. We always speak about social determinants of health, and that, you know, healthy communities mean that individuals are going to be healthy. And if our communities are not healthy, there's problems. And certainly I think mental health portrays itself even within that. And so this morning for you, which is afternoon for me, I'll just be giving you an introduction just into this topic and mental health within a South African perspective. Really show you a bit of how it's been integrated into primary healthcare within our setting, but also what are some of the nuances with regards to healthcare systems in a South African setting and the difficulties that we might be coming across. And then again, psychiatry in itself. I am not a psychiatrist, but as a family physician, I did a little bit of psychiatry to be able to understand it and to be able to function within a district level hospital, which practices mainly in sort of semi-urban and rural communities. Yeah, and then just the community involvement in mental health issues. What are some of the community involvement? What about tradition? complexities around social cultural factors that we need to be considering when we're speaking about mental health. I'd like to start with a case, and this is Mr. Ngubane. Mr. Ngubane is a nearly everyday patient that I would see in a rural South African context, in a district hospital or within the community. And basically, Mr. Ngubane is coming from our local community. He's brought in to the hospital by the police because he was picked up when the community actually complained that he was being destructive. He was breaking windows. He was verbally aggressive. He was walking around naked. And there's no family member that was accompanying him. He's apparently living alone in a one-bedroom shack. So it obviously has no windows, there's no electricity, there's poor sanitation within that particular setting. He is known, though, to one of the casualty nurses because she is from the community and she knows about Mr. Ngubane because they've seen him around, walking around multiple times. He's also been seen at the hospital for previous admissions where he's admitted for what we call a 72-hour observation admission in a district level hospital, which is basically with any other patient in a general medical ward. And then from there, once he's completed his 72 hours, he's referred to a psychiatric institution for further care and further admission if he's deemed to not be having acute psychosis. So he's admitted into our ward under the Mental Health Care Act, and then is transferred to a psych hospital where he spends 2 months admitted there. And then he returns to the district hospital, which is where I work, and is discharged home thereafter. So this really gives you, I think, a picture of a patient, and if I could use the word, a typical patient who has a psychiatric illness, who comes through our healthcare system on any given time and any given moment. This is the route that they would usually take. And so keeping this case in mind, I'm going to be going through different aspects that we need to consider when we're speaking about mental health in a South African context. And I'd like you to really keep reflecting back on Mr. Ngubane and some of the difficulties that he would face within the system and what I'll be speaking about today. Now, I think South Africa, certainly over the last probably 15 years now, we've had multiple issues when it comes to mental health. It has been something that has been looked at very closely. We had a situation in Johannesburg, which was the Life Esidimeni tragedy, where basically psychiatric patients who were within a particular facility that was an organization which was subsidized by government, because of certain issues, politics, government decided they're going to pull the plug on that facility, and they wanted the individuals to be transferred to other settings and other facilities. And what that did is it killed hundreds of people. It basically displaced many people from even their families. And this was a massive cry out from the communities, from the families. And these cases went on for months on end, with really solutions trying to be found as to firstly what actually happened. And there was a lot of blame game that was happening amongst structures within our healthcare system as to who made decisions and why they made decisions, and this was really, really problematic. But it highlighted something that we've been dealing with in our country for many years on end, that really human rights in terms of individuals who have mental illness are not something that is highly regarded, as much as potentially through policy it is, but outside of policy, there are multiple issues there. Then, of course, we went through the pandemic years. And I think with the pandemic years, these really deepened mental health challenges. And I've put pandemic years in small letters there at the top, just purely because I'm, secretly hoping that we never really go through another pandemic, which we know through research modeling and so on, we know that we probably will. But I think the effects of what happened with the pandemic, and specifically on mental health, it affected us quite heavily. I think worldwide, there was increased unemployment, but certainly in a South African context, what we saw was between 2.2 to about 2.8 million people who lost their jobs in a space of 3 months, 2 months even. And there was increased depression and anxiety in terms of cases that we started to see. So the system became flooded with patients because of issues that they were facing up. But also at the same time, because the focus was so much on COVID, we did notice that there was a lot of patients who were lost to care, lost to follow-up, who are mentally ill, who wouldn't naturally present to the hospital if they've got a psychiatric condition without being referred. And so we really were sort of like not seeing these patients. And this didn't just happen with mental illness, but it happened with even illnesses like tuberculosis. All of a sudden, we weren't really diagnosing things like tuberculosis, which in a South African context, we see quite a lot of it. So this brought on quite a number of challenges for us to think about, which meant post the pandemic years, obviously the burden of disease, especially around psychiatric illnesses, did rise quite drastically. And so we started seeing more and more patients. I think globally, it is important that we have a bit of an understanding that I think even globally, there's little attention that is actually paid to mental health. And in the high income countries, 5% of their spend on health, on the health budget is actually on mental health, whilst in low middle income countries, we spend about 1% on average. In Africa alone, 70% of our countries spend less than that 1% on mental health, which if you think about how much mental health we're seeing, it really is disproportionate. And so the untreated patients who have mental health illnesses would be accounting for over 13% of the total global burden of disease. And this was according to the World Health Organization. So psychiatric disorders, really both in developed and in developing countries, actually represents a major burden of care. And it's important that we consider the disabilities and losses to economy that actually happen because of this as well. Statistically, it was projected that depression would be a leading cause of disease burden by 2030. I think post the COVID years, we've probably brought that right down, probably by 5 to 7 years, because we are seeing a lot of depression at the moment in clinical practice. And this certainly is impacted by what has happened in the last 3-4 years. But overall, what still is problematic within certainly our country and within a rural environment is the stigma that is attached to someone who has mental illness. And there is a Zulu word that is used for someone who has mental illness, which in a way is quite derogatory. And it actually ostracizes the individuals and portrays them as not a part of the community. And, people often would refer to an individual who has a mental illness in that particular word, and it automatically places them and gives a particular picture. And that just tells you the stigma that we are experiencing when it comes to mental health illnesses. And so there's a lot of unspoken burdens that we face as well within our societies. And certainly in the primary healthcare space, a quarter to a third of the disorders are psychiatric in nature. Majority of these actually presenting with physical symptoms to our casualty settings. And so many organizations like the World Health Organization, the World Organization of Primary Healthcare Doctors reiterate the need for an integrated mental health care system, especially that is portrayed towards improving how we manage mental health in primary healthcare settings, where really our focus is biopsychosocial spiritual rather than purely biological in the way we approach it. And thus the essence of holistic patient care becomes very, very critical in managing patients. So now looking, I think, deeply into a South African perspective, I think everyone would be aware that we went through apartheid. And post-apartheid years, democratic South Africa inherited really a fragmented healthcare system that was strongly under-resourced, certainly within the public healthcare sector, and mental health services were close to non-existent, really. 50% of our total population and about 70% of our poor live in rural communities in South Africa. And a lot of treatment in terms of mental health has always been reliant on centralized institutions. So our big hospitals, which are central hospitals, which have then all the specialists and so on. Even many of our mental health care centers, which are big hospitals that admit patients for a prolonged period of times, are in cities and not necessarily out in the poor, in the rural environments. And so you can imagine even the divide in that for family members to be able to engage with care and ongoing care for individuals who are in these particular facilities. It becomes difficult because they might be 5-6 hours away at a particular institution where they are getting care. But great strides in ensuring mental health care services have taken place, and they've tried to make sure that there's equitable healthcare that is in keeping with the health policies that were coming up within the South African setting. And so really there was quite a bit of recognition that mental health services is an important health issue in the country. With 20% of our people attending the primary health care suffering with mental health illness, it needs and continuously needs more intervention for us to provide care appropriately. Yeah, and so as much as proper mental health care is lacking within a rural South Africa context, and this has even been raised by certain campaigns that have happened where they've said that, it's dehumanizing the state of mental health care. And I think even with looking at the disproportionate distributions of mental health resources from urban to rural, and majority of our psychiatrists being in central institutions and no psychiatrists within a rural context, there is some mental health that is still being practiced within our rural communities. And it is important that we identify that. There was a doctoral study that was done that looked at, just investigating the state of rural mental health in South Africa. And this was a significant study because it showed that care for people with mental illness is also about prevention and promotion of mental health rather than just being curative. And so that was important, and especially within a rural context. And this study also emphasized the importance of having a model that is community-based in approach, including other spheres of health within our settings and our communities, such as traditional health providers, religious societies, NGOs, and so on, and saying they're playing a pivotal role in taking care of individuals within these settings. And so interventions need to be locally relevant, which is very critical, and culturally consonant, as culture actually shapes the illness that individuals experience within a rural community. Now, Western care with medication may not always be the most effective intervention, certainly for mental health illnesses in rural, because of all these other factors that need to be taken into place. And I'll go into that a little bit later as we get to the social cultural factors that actually affect mental health as well. So the integration of mental health care services in the country was that South Africa has integrated mental health care services into primary health care through legislation. And I think this legislation was critical because it holds us accountable to say, are we at least trying to do the best we can for individuals who come in with mental health care illnesses, and not necessarily just lock them up in a room and forget about them, which on many instances was the case. And so really the policy and legislation advocated for community-based services and ensuring that communities are engaged and involved in the care that is happening. Unfortunately, the implementation of this has been uneven across many of the provinces. And this is purely because, one, the provinces control their own services, healthcare services, as much as National Department of Health will come at a policy level, but in terms of the outworkings of health services, that is purely at the control of provinces. And so certain provinces will choose which illnesses they want to focus on in any given time. But also human resources and resources overall was problematic. And so it's difficult to come to a district level hospital that has 150 beds, which are always full, to now say part of those beds have to be strictly for psychiatric patients. Those are some of the difficulties that we're facing up. Staffing, because psychiatric patients need constant monitoring to make sure they don't harm themselves at the time when they are psychotic, for those who are psychotic, but also for those who have other mental illnesses. How do you provide the other services that are relevant for the appropriate healing, like psychologists and counselors and so on, which again doesn't really exist within our rural structures because of lack of resources for many of these individuals. And so, yeah, so more focus really then was put onto improving the emergency services for psychiatric services in the rural and district hospitals, because a lot of patients were presenting with emergencies and saying, so how can we actually prevent this? Which really goes against the community-based type of model of care. I think just a little bit of information about how the system in South Africa is located. We've got a public healthcare system, we've got a private healthcare system, and there are other components that we need to always be considering. So traditional healers, alternative medicine, which we see a lot of, and then there's obviously the non-governmental organizations and community-based organizations and faith-based organizations that are all trying to provide some form of healthcare. If you think about mental health, though, it is intertwined into all of these different structures. And so it is important that there's some level of coordination between these structures, which unfortunately at the moment doesn't really exist as much. Government has been doing quite a lot of work, particularly in trying to include the traditional healers as a part of the healthcare system and recognizing even some of the referrals that they might be sending to us within the hospital setting, and having that two-way communication to make sure that we're able to engage appropriately as we are treating patients. Oftentimes, I would see patients who come in and they have a cultural understanding of their illness rather than a Western understanding of their illness. Patient comes in and has a cerebrovascular accident, for instance, might say to me that no, someone put a form of muti, witchcraft, at their doorstep, and as they walked over this, they then obviously fell over under this particular spell, and that is why a part of their body is not working. And individuals are really entrenched in that type of belief system purely because of their culture. And so if I just come from a Western perspective and negate what they are saying without really trying to understand it and working with them through it, I lose them. And so all of that needs to be taken into consideration. So how do we start to really include that understanding in the way we're practicing medicine, whether we're within the public sector or the private sector within South Africa? I think even the inequity in a South African setting is quite deep. You know, when we look at the way we spend our money, 4.1% of what we spend is for 16% of our population, which is covered by the private healthcare sector, whereas 4.2% of what we spend is for 84% of our population, which is covered by the public sector. Now, you can imagine that a lot of psychiatric conditions are within that 84%. And so how much then is being spent on them? When we look at urban and rural in terms of setting, our rural population is nearly 50% in our country. And again, in terms of resources with regards to doctors and nurses, or just healthcare workers overall, literally only 12% of doctors and 90% of nurses work within a rural setting out of all the doctors and nurses that we have within our country. And again, the models of care, our hospitals are very curative in nature versus preventative care. And so trying to push community and preventative care becomes critical if really we are to think about breaking down that inequity that we are seeing. And yes, we've got lots of human resource constraints, the fragmentations of services, as I've spoken, the poor coordination between the different levels of care as well do affect mental health, certainly, and how individuals are going to be managed. And then I think if we come into psychiatrists themselves, so in South Africa, to become a psychiatrist, you firstly have to do an undergraduate training degree, which is a 6-year program. You then do 2 years of internship, where you are now a qualified doctor, but under supervision. And then you have to do a year of community service where you are placed in rural communities to serve those communities in general medicine. So you do everything from obstetrics and gynae, so cutting cesarean sections, to managing babies who are sick, to seeing the elderly, and going into the community and working in the community with the teams and so on. Then when you've done all of that, you can then decide that you're going to specialize into one particular stream. And that's when you then engage in a specialist training program in the cities, which is our bigger hospitals, to become a psychiatrist or any other specialty. But I think for the purposes of this talk, in particular, a psychiatrist. Now, according to the South African Society of Psychiatrists, we have about 350 plus practicing psychiatrists in South Africa. And that number stays stagnant many a times because individuals emigrate as well. And so as we are producing, we are also losing quite a number of psychiatrists in the country. But 60% of those psychiatrists are in private practice. And so 40% are trying to serve that majority of our population. So we've got about 0.39 psychiatrists per 100,000 population, which makes up one of the 45 countries worldwide with less than one psychiatrist per 100,000 population. And these are old stats, but they're quite similar in terms of even now, I'm sure. So there's a massive need for creating a different cadre of healthcare professionals that actually have skills in psychiatry. And South Africa did certainly push this in trying to raise the number of psychiatrists from the perspective of, not being psychiatrists themselves, but nurses, for instance, who are trained in psychiatry, who are able to engage in community psychiatry, making sure that the doctors are upskilled, even though they're not psychiatrists, but to be able to manage psychiatric conditions. And so I think the improvement and training of a different cadre would also ensure servicing of communities that are mainly in need. I think when we think about how we practice psychiatry within a primary healthcare space as well, we see a lot of emergency presentations, patients presenting aggressively, patients presenting with suicidal ideations, patients who've been exposed to violence and trauma, patients with anxiety, stress, mood disorders, and obviously complications of substance abuse. And I think in particular with the substance abuse, we were even seeing more and more patients who are coming in with use of ARVs and using certain agents, certain ARVs, to actually induce, the ARVs themselves would actually induce psychotic disorders. And so we were seeing much and much more of that within our settings, which again was becoming problematic. And outside of that, even other drugs that individuals are being exposed to is becoming quite a huge burden on our healthcare system, and in particular our primary healthcare system, because that is the entry level for anyone who has a medical condition before they are sent to a centralized hospital. And there's, very minimal involvement from communities as well and families through few support groups that I established. And I think in a rural context, support groups are not really a big thing. I think, as I've said, with the divide that is happening between urban and rural communities, urban communities certainly have more resources available to them. So, there's more NGO supports as well for mental health illnesses. Individuals don't necessarily have to be admitted in an urban setting to a hospital, but they can be admitted to a mental health facility that is not necessarily like a hospital setting. They can go into what we call, for instance, the Midlands, where it's just vast beauty, land, you name it, beautiful hills, rivers, and they're within a mental health facility to get help and to get restoration. But that is all great for our for our urban communities, but that doesn't exist for our rural communities. So the divide again in resources is quite massive. The poorly structured programs also is problematic, specifically at community level, in trying to assist individuals on transitioning back into their communities. It really is non-existent on many levels. And really our focus has then always been, how do we advise families on how to take care of their family members when they go back to their homes, rather than how do we support them even in the process when they are at home. And so that is quite a big lack that we are seeing within our health structure as well. And then, when we think about these social-cultural factors, so modern Western medicine is obviously acceptable within our rural communities, but traditional belief systems still dominate. we know that as we practice, we've actually have always been second choice for many of our patients. Over 80% of patients within a rural community have sought traditional healer help before they actually come to us in a hospital setting. And so having an understanding of that becomes critical, because it then helps you in how do you then help manage this patient further. You are second choice in terms of them coming to seek help from you. And so how can you advise and make sure that you try and make sure they're taking the medication that you are giving, but also thinking that they're probably taking herbal medication at the same time? What are the drug-to-drug interactions that are going to be happening there? How do we step away from a blame game and rather think on how can we work together with this particular patient? When we think about traditional assessments and treatment of mental health, it is quite complex within a cultural system, because there's traditional diviners, for instance, which do something totally different. They use, divine interventions to try and actually treat their patients, make diagnoses, and so on. You've got traditional doctors that use actual muti medicine to then treat their patients. You've got faith healers and prophets also that come into play. So all of these different elements also try and work together, and sometimes different, to make a diagnosis. And so when the patient comes to us, they could come from any of these spheres, telling us exactly what they have or what they believe they've been healed from. And so we need to take cognizance of that and understand it in terms of how we would help patients in moving forward. I think also our country is very diverse in terms of culture. We've got 11 official languages, and access to mental health care is still compromised by the fact that few of our psychiatrists actually speak the indigenous languages. Yes, a common language of communication in South Africa is English, but if we think about our rural communities, many of them do not speak English. And so how do you consult an individual when you don't really understand what they're saying, and especially with mental health care issues, because language there is different to someone telling you that I am coughing and I'm short of breath and I've got fever and so on and so on. So how do you start to understand really the intricacies of what they're experiencing mentally to help in making a diagnosis? Also, there's further compromise in the quality of mental health care being provided, again, as language is at the heart of the mental health care, of mental health care within these settings. So over the years, the cultural factors included in the diagnosis and treatment of traditionally oriented Black psychiatric patients is obviously having to change. So when we think about things like hallucinations, which could be associated with what the patient believes and their ancestors, that needs to be adjusted. When we think about things that they see, many times we would call that pathology, but over time, I think there's been more understanding of, okay, so how could this be included in how we manage a patient? How could we start to understand some of these cultural factors in the way we manage patients? And so we needed to start really considering collaborative models and practices between traditional medicine and Western medicine to actually be able to assist individuals appropriately and to then provide the best quality care that we can give. So I think really to end off, I've given a picture of these different components, I think from a health systems perspective, from the patient perspective, from a community perspective, from a cultural factorial perspective. But ultimately, we're still stuck with Mr. Ngubane, who, again, is from this local community. He's brought in because he's disruptive within the community. He has no family to go back to. He lives alone. He is known by community members, but there's no real intervention. He gets into a system that he has structured to be able to try to help him and protect him, takes him to a psychiatric institution, but he can't stay there forever. He's sent back because of space issues, resources, and so on, and is discharged to go home, in inverted commas. But really, what happens to this individual? And that is the real question that we need to be thinking about. Thank you.
Thank you so much. That was incredible. And I think when I introduced you as, a wide range of expertise, it makes sense that you gave such a wide-ranging and all-encompassing talk today. Um, so I'll open the floor for questions. I can start with one. I think I was really interested with, in terms of what you were talking about with healthcare spend on mental health care. First of all, the numbers are staggering. I mean, less than one psychiatrist per 100,000 people is just a staggering number. But I was curious, when you talk about, how can we show that this lack of spend actually equates to losses in the economy empirically? And I was thinking about what you were saying about it's up to the provinces to decide how to allocate funds. And so you think about provinces making that decision. Do we give this to a psychiatric bed or do we give this to something else? What ways have you seen to be effective in sort of almost proving that out empirically to kind of convince people, okay, this is actually worth the time now in a preventative measure because down the line it's going to cost us more.
Yeah. So, there's been lots of efforts, I think, in terms of research, because individuals do listen to statistics on many aspects, and especially where there's not just morbidity, but mortality associated with it. And if that mortality is documented appropriately, then individuals listen. I think what becomes difficult with that is many a times those who are doing the research can only be viewed as, well, you're stuck within an academic space. You don't really know what we're dealing with from an economical space, with regards to trying to provide, whether it's to building homes, to building road infrastructure, to and so on and so on. And that becomes a bit of a problem. But what we have noticed is that those who are in the government and leadership structures do listen when they can see that there's documented death and disability. And so that has helped, even in certain meetings that we're having with Department of Health, and politicians, if I can say, it helps when you come with statistics and you say, but this is the struggle, this is what we've seen, this is the effects that it's having, and then adding to the problems in our economy, because more and more people are being disabled in this manner. And so we're not going anywhere, we're not growing. We need to sort this out at the root level. And I think that does speak to a lot of them. The difficulty in that, though, is that the turnover is quite high within those high structures. Individuals don't sit in positions for 20 years or 10 years. They sit in positions for 5 years maximum, and then they're out because it's new leadership. And then that new leadership needs to be convinced again on the issues that are happening on the ground. So you build momentum. By the time you get to start to winning, you try and get to the policy level. And as you're about to change policy or affect change or care, it changes. And the next person comes in and says, I'm not signing on that because it's going to cost so much money. And is it really worth it? So show me the evidence again. So those are some of the issues that we have. But I think just continuous engagement with those structures and continuous research in this sphere, and showing continuously that we're doing something to try and help, but we're struggling, becomes critical. And that really then shows individuals that we need to do something about it. And then, of course, we have the situations like Life as it Yemen, which come and we have mass loss, which then, blows up in everyone's faces. And now it becomes a health crisis. And those health crises then become, again, a voice where we jump on those, and we add our voices to those so that now everyone can see this is a problem, and it's not a new problem. But now that many people have died, we're talking about it, and so on. So yeah, so all of those measures become critical. So it's really around health advocacy. I think it's one of the critical roles for us as healthcare workers. How do we continuously advocate for patients? Even when you are at risk of losing your job, how do you advocate for a patient? Because that's what you said you would do, right? So how do we do it continuously? Yeah.
Thank you. Yeah. Any other questions from the crowd? feel free to unmute yourself or put it in the chat. I can also keep going. I have many.
Can I ask just one quick question? Well, it's actually quite complicated, but when it comes to mental health in the community, the patient that you talked about was one that didn't have family, but I know that the world is changing a lot, but in a lot of places we have this kind of more collectivist or community approach to mental health versus the more individualist that we see in the US. And there are a lot of, more people that are, sitting home alone, nobody really paying attention to what's happening with them. Do you feel like there is this shift towards a more individualist society, or do you feel that there are people in the community, and especially in rural communities, that step in when folks are dealing with mental health issues?
So I think what we've been seeing, which actually is stopping individuals from stepping in, is the issue around stigma. And I think that stigma automatically says, well, if I associate myself with that individual, I could be deemed problematic myself. I could be seen as, but how are you able to engage and help an individual who has a mental illness? And I know I'm talking on the extreme here with regards to a psychiatric or a psychotic disorder, rather than even just purely depression or anxiety or, a mood disorder. So yeah, so that I think is one of the big problems that we see, and really stops individuals from engaging and acting. And why I'm saying that is because what we know about certainly a lot of our South African communities, this whole emphasis on Ubuntu, which is I am because you are, it's community, is there. People are always helping each other out. I mean, I remember when I was getting married, we had 750 people at our wedding. My wife and I wanted 250 people at our wedding, which we thought was a number we could handle. But the extended family was saying, but no, but that individual helped you out when you were 5 years old and we needed this. And that individual did that. And so that's the sense of community that is already there and existing. Now, with mental health, though, it's as if there's this step away where, no, we can't step in, we can't help that individual. Oh, no. It's like, let them be. That's sort of the help they're getting. Let them be alone, but then no one helps them. So there's a lot of that that we're seeing. But also, I think the violence that is associated with a lot of mental health conditions and individuals who have mental health is then what also further divides that sense of community, where individuals say, well, we're not going to help because they're aggressive, they are harming us, they are stealing from us within the home to go and buy more drugs, to go and sell this and that. And I think those are some of the issues that we've been seeing. Much of that, and what I've said is anecdotal, but I'm sure it certainly has been documented, as a problem, to see how we can actually try and help. So government, what they did though, is we started having community healthcare workers, which are working within the community, who will then know the different households and individuals who need help, who need, groceries and so on. And that community healthcare worker then goes into their home and actually tries to assist. They need taking of medication. So that community healthcare worker tries to assist. Again, to try and, show people that this person is still a person who needs our help as a community. I don't know if that answers your question, Tracy.
Yeah, thanks so much.
Pleasure.
If no one else has one, I guess I'd be curious, I feel like especially with mental health, but with all healthcare, sort of in the global health setting, sort of the most important tenet is kind of building trust, and to do that, spending time in those settings. But I'd be curious, with your partnership with UCLA, and I know there's a lot of people on this call who, are in the global health pathway or concentration and are thinking about sort of ways that they can get involved in settings like yours. How can how can students like us be helpful rather than harmful in those settings?
Sure. Thank you. And a very good question. And I mean, so we've obviously been having multiple talks, I think, with Tracy and Zoe and the team, just in terms of how our collaboration can continue to be strengthened and be bi-directional. And part of you guys hosting us was even in that and saying, so how can we really see how these different worlds can come together and assist each other with understanding healthcare, but also improving how we're doing healthcare services. I think what has come out is really excellent, where there's opportunities again for research. And as I said, by documenting a lot of research around problems, we highlight the problems and we ask for solutions. Because when people read and they can see, oh wow, okay, so that is a problem, yes, because it's been documented in that way, and scientists have documented it. They want to act on it, right? And it just gives us a lot of, I think, strengthening in when we're bringing about and asking for solutions. So I would say a component, yes, is assisting on the research space. And I think there's been a lot of discussions again where individuals are actually coming across and will be assisting in different spheres around that. But also, practicing within these communities is a lot of help. And understanding the communities and actually being that extra hand is a lot of help. And so what we are seeing, and even every single time we are hosting anyone who's not from South Africa in any of our hospitals or our settings, it is with that hope that as much as they're there to learn, they also will hopefully possibly be back to come and help further. And so really that exposure becomes critical, because an extra hand is always important. And I think when there's an understanding on even issues like this, I know we're speaking about mental health today, but you bring in expertise as to how we can help solve some of those issues, it becomes very helpful. And one less psychiatric patient seen by another doctor is helpful, because you're able to give more time to that patient that you are seeing to try and assist and so on. So don't negate that, as much as you guys will be coming to learn and to experience a healthcare system, but rather also you actually giving quite a lot, in that time, which is helpful. And then, in terms of postgraduate and studies and so on, that is very helpful too, because it's helping to shape and change the way we're doing things and improving. So so that would be my advice.
I just wanted to add to that if there are folks that are interested in working, with Thandaza and colleagues in South Africa, just reach out to me and we can, be sure to connect you. And also the fourth year rotations that are done with, at some of the hospitals that Dr. Thandaza manages are like some of the more popular ones, and just really so much learning happening that we get to see through the students' reflections and the reflective writing that happens there. And in particular, like the really interesting ways that you work with traditional healers in the community and, work with patients to understand what kind of healthcare they've been seeking, and removing that stigma. I think that's really unique, and has been a valuable lesson and takeaway that's pretty unique to your setting. So I just wanted to throw that out there, but I'd be happy at any time to talk to folks about that.
Thank you.
Great. I don't also, do we have till the end of the hour? I don't want to keep you.
Well, I think that the students actually, many of them go to class right at 8, is my understanding. So the early mornings are sometimes a little bit challenging because we're adding it into an already busy day. So I don't think that we need to stay on, but would you be available if folks had questions or wanted to learn more about the work that you're doing with UKZN?
Absolutely. I'm more than happy if you want to share my details. I'm more than happy, and we can certainly continue communicating, and I'm happy to share whatever insights I have. Which is always helpful.
Awesome. Thank you so much.